Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Stephen Zonner. Dr. Zonner earned his medical degree at Midwestern University before completing his family medicine residency at Bodsford General Hospital. He completed his fellowship at Rush Presbyterian St. Luke's Medical Center. Dr. Zonner is board certified with the American Osteopathic Association. He is also a member of the Washington Township Medical Foundation.
I hope you'll find this to be an interesting talk, because since I've last talked about this approximately about 8 months ago, a lot of things have changed, or at least our approach is changing rapidly. Now, this slide, if you can read it, basically the idea of it, it says there's a machine and it's placing a device on top of these football players' heads, and it says "Concussion be gone." And the gentleman, I guess he's the athletic trainer, is applying it, says to another gentleman on the sideline, he says, "Yo, Dewey, got another one over here when you're done." And I think that's a perfect segue into what is going on in the community right now, is that I'm sure there are a lot of people that you'll hear ideas about new mouth guards, new helmets, new devices. And I will be talking tonight also later in the talk about a new device that we are getting that is not a joke. It's actually quite an expensive and sophisticated piece of equipment that will allow us here at Washington Township to be one of the first centers, along with Stanford, to be able to diagnose a concussion in less than a minute. And we can do it on the sidelines. And it's not with a funny device like this. So it's very exciting. So the talk tonight is what I would call big changes in concussion care. What you don't know can hurt you. And that's always the case, is it not, in medical care and in general? If you don't know something, or you think you know something, that can definitely come back and haunt you. And with concussions, I think everyone's afraid, and the fear is considerable because it's your brain. It's probably the most important organ in your body. So let's go into what a definition of concussion is. It comes from the Latin incutere, which means to shake violently. I mean, it's interesting, right? Whenever they created this term a while back, many, many years ago, hundreds of years ago, the term is very applicable. And as I get into the talk, you'll see why. This concussus, striking together, shake violently, these forces are the forces that are altering the function of the brain. I'm using the term MTBI is another term for concussion because it stands for mild traumatic brain injury. So there is a concept or an entity known as traumatic brain injury, where you actually have visible structural damage, can be seen on an MRI, and you have mild traumatic brain injury or concussion, as it's understood by neurosurgeons and all the physicians alike, that is a non-structural injury, and it is what is called a neurometabolic crisis. Wow, big word, big term. It's an energy crisis. Basically, it is a lack of energy in the brain, and we'll talk about how that occurs. So it's not anything you can be seen, it's strictly an energy crisis, and the brain slows down. What are these facts now that we have about concussions? We have about a rate in the general population of about 6 per 1,000. That number goes up to as high as 13 to 15 for football, hockey, around the same. You know, these rates change. The statistics that you'll hear bandied about are about 1.6 to 3.8 million. It's a wide range, but I think most researchers in this sphere agree that now that is well over 4 million, and we're getting what is called a field effect, meaning that as the public becomes more aware, we're getting more referrals and people are being more open about it. And the problem, of course, is that if you're not open about it, or you don't recognize, what you don't know can hurt you, if you don't recognize that you may have a concussion, some of these symptoms can just go on going for at least a year or more. So we're saying a rough estimate is about 15% of these symptoms lasting greater than a year, and about 80%, and I would venture to say even more with more advanced care, we're 80% or more are resolved in 3 weeks. There's certain age groups that are more at risk for prolonged, and we'll talk about that more later. So back to the question, what is MTBI, or what is a concussion? So we say it's caused by a bump, blow to the head, and here's the kicker, or body. How can you get a concussion from your body getting hit? Well, if you understand that, then you've got the whole gist and the importance of understanding this whole talk. What happens is that it's basically a whiplash, if you think about it. What's happening to the brain, it's a whiplash effect inside the brain. And so if the body gets hit, and you can imagine that the neck is whipping and the head is whipping and the brain inside is whipping. And so, as I'll show you in the next slide, you'll get a better idea of how this might be occurring. But what happens with that whipping, and as the brain is stretching, the axons, those actual tentacles that are connecting our brain, are stretched, and that causes a disruption in metabolism, in cellular metabolism. And of course, with that are the electrical impulses. So this is a very busy slide. For those of you that are medical professionals, I refer you to this article. It's a classic article by a gentleman named David Hovda out at UCLA, and this gentleman has done a lot of incredible work with concussion. And basically what you should get out of this slide is that there's a lot of chemicals usually these chemicals are staying, they're right in the middle here, they're fine. You get disrupted, it gets stretched, you get a release of calcium, potassium, everything goes out of whack. And the brain can't think well in this. And on top of that, this part right here, this line is showing you the cerebral blood flow. So there's actually a minor decrease in cerebral blood flow. So things are not working well. And now the other important point is this timeline. You'll see here, this is about 10 days before this is coming back to normal. And that's in an average person who's just at rest and not doing much. And we will find out later, we'll talk about how our change in protocol is changing this whole metabolism to enable athletes now to get better faster, and with some very startling and exciting results. So this is a really nice slide. I like this because this gives you an idea of what is happening in a concussion, and we talked about the whiplash. So if you can picture, the brain is obviously oblong shaped, and if you've ever picked up a bowling ball, weighs about what, 11, 15 pounds? I'm not a bowler, so I don't know the exact weight, but you can imagine that it's tethered down here. It's free on this end, it's tethered down here. And then through this area of the body, whenever there's a force to the head, it could be in any direction. We tend to sometimes think, well, that's just the brain got bruised in that area. But very often, there's a reaction, or the body will shake and move, and you'll get a little whip. So let's just think about other things that you may not be aware of that can cause concussion. Car accidents. Now you might think about this if you're a clinician, and all those people we saw that we're thinking, oh, they just got a headache from neck pain, and the fogginess, and we get into the symptoms, all these other myriad of symptoms we were thinking it was just due to a headache from the injury. 80%, I would say, venture a very conservative guess to say that 80% of victims with headaches, if you relook at their whole constellation of symptoms, have sustained a concussion, and they didn't hit their head. So that gets back to the body, and then gets back to this slide here of what's happening. And so in essence, the front of the brain is being, where this is the farthest away from here, the front of the brain is getting stretched from the back of the brain. And with getting a little more sophisticated here, the cerebellum is an area of the brain that's very important in controlling our emotions. And the front of the brain is important for controlling our emotions and our abilities to think, they call it executive functions. If you decide, I need to go out and go to work today, I need to study tonight, I need to set aside time for this, I need to hold back, I need to tell the truth now, Oh, I think I'm a politician. I might not tell the truth now. I mean, all these factors are taking place in the front of the brain, and the back of the brain is controlling our, it's kind of like the brake on our emotions. And I mean motions and activities. So what are the symptoms of a concussion? I think most of us would recognize, and everyone would raise their hand and say, yeah, probably the biggest is a headache. And that's true. It's up to, it's probably 90% of people present with a headache, or they might describe it as a pressure in the head associated with that. And the most pronounced symptoms, by the way, are in the first 1 to 2 days. First 24 to 48 hours is when you're going to see the greatest changes. So again, I'll touch base on this again later, but always keep in mind that these symptoms can change over the first 2 days. They may not have them at all at the time. You may watch your son or daughter play a sport and see them really get hit hard in the body or the head, and you might say to yourself, wow, I better talk to them later. They've got to have a concussion. And they can talk to them and they say, no, I'm feeling fine. Get them home later that night, and all of a sudden they're feeling sick and they've got a headache, or the next day. So these symptoms can change. The other problem is imbalance and dizziness. So I would say that these symptoms alone, mainly headache and dizziness and balance issues, are some of the predominant symptoms that we see in concussion. Another one is feeling foggy or groggy, or they just don't feel right. They might even have, hazy vision. Their vision may be off. And that gets into something where we know that the tracking of the eyes is extremely important in how we react to a concussion and how we view the world. No pun intended, we're very visual animals. And our brain, as a matter of fact, is using our eyes to stay about 2 seconds ahead of what our reality is. So if somebody throws you a ball, your brain has got to be able to think ahead to know where your arm should go to catch it. Or if somebody's about to bump into you, you've got to be able to think ahead enough to know where you're going to move so you can get out of harm's way. And when your brain is racked or damaged or having this metabolic crisis, it doesn't think that fast. And the eyes are trying to find their way back into a synchronous pattern with the brain, and that's when problems occur. Obviously, a loss of consciousness is a very concerning phenomenon. And when we talk about a loss of consciousness, in general, we talk about 30 seconds or less, or 30 seconds or more as being important. If you're fortunate enough to have a physician who knows something about concussions at the sideline, they can help you make a decision on whether or not that person needs to go to the emergency room. But in general, suffice it to say that if you have an individual that has a loss of consciousness as part of their complex, you really ought to be ready, be thinking, maybe I ought to have them evaluated by a professional. Now, moving on, let's say you decide, well, it was a brief loss of consciousness. So, and they're walking around and they're talking and they're feeling fine, and you're like, well, I'm pretty sure they lost consciousness. Let's use an example. How many of you have ever seen on a football game, a receiver get a football, get hit in midair, and if you look very carefully, you can see their body go limp and they hit the ground. The TV commentator probably doesn't comment, but that person is probably unconscious as they're hitting the ground. And they lay there for a few seconds and the trainer comes over and no one knows any different. But that's an important thing to remember that. So when that person gets up and is being evaluated, if they start to move clumsily, or they're just unsteady, they can't stand, or they've just got a severe headache, slurred speech, I mean, you get to know your family member pretty well. If something like that's happening, then just call an ambulance. Don't take them yourself. Get somebody to transport them. In general, so moving on, we've got, obviously appearing dazed or stunned, sensitivity to light and noise, very, very common with concussion. Obviously, other clinical signs would be answering questions slowly, maybe asking people to repeat. Another one that may shock you, but it may fool people, is that you get an athlete pulled off the sidelines with a concussion and they're just super revved up, maybe emotional, maybe crying. And you think, well, that makes sense. That was a very big play and it's the end of it's the fourth quarter and we needed a touchdown. But keep that in mind, that emotional outburst comes from the lack of control from that prefrontal cortex of the brain. So that could be another sign of concussion. Obviously, being confused about your assignment, running back on the field when the defense is out there in your offense, or even just not being sure of a play. That's one of the ways that we can get coaches to buy into this whole concept of concussion, because I think they want to win. And if we can convince them, it's better to keep them out and make sure that they're safe to return and that they're not going to screw up a play. I think the coaches are sometimes more happy to hear that. Other clinical signs, obviously you can ask about the score, the period, who even the opponent is. And if they can't recall an event, this is something that is more for ER doctors, but this is a term we call retrograde or anterograde amnesia. Amnesia, of course, is not being able to remember, and retrograde means that they can't remember the event that just happened. Anterograde means they're just having trouble remembering everything going forward. So these are also symptoms that are concerning and obviously would scare people, but they don't necessarily mean that this person's got a bleed in their brain or what have you. So what do we want to do when a person has a suspected concussion? And it's often forgotten, is to exclude a neck injury. This is particularly important if somebody's unconscious. And if you've ever been in a situation on the sidelines, it is a tough situation when you get wrapped up in the game and you want the game to keep moving. I had a youth in a hockey game with 18 seconds left in the game. He got rocked against the boards and his neck was hurting. He wasn't unconscious. I did the whole check. And everyone's like, oh, come on, it's 18 seconds, let's just go home and we'll call it a day. I said, oh, we've got to make absolutely certain that there's no neck injury. And we spine boarded him and we sent him to the hospital and we got an x-ray and made sure that there was no injury there. So that's an important thing to keep in mind, particularly if somebody's unconscious. Don't let them go unless you're sure of that. And you can do that by palpation. And I think, from my experience, if somebody's got a neck injury, they will tell you. You may have to ask them, but you say, how does your neck feel? They say, that's okay. And then you can touch it. And if it's not sore, then you're pretty certain that they're okay. If somebody who's got a broken neck, they're going to say, I don't feel good. This is hurting. I don't feel good. They may have neurologic symptoms. That's definitely a person you do not want to move. You keep them positioned in one place, and hopefully you'll have a professional there to help you. Pupil assessment is another one that everybody thinks about when they see concussion. The first thing anybody does is they get the pen light out and they're shining it in the eyes of the patient. And we want to make sure that the pupils are equal. Well, I'm here to tell you that, first of all, unequal pupils, it's a medical term called anisocoria, is a very common problem. Up to 6% of people can have naturally unequal pupils. And so what we will do when we do our physicals with our high school students is also make a quick assessment whether or not they have this condition, because obviously a person's down on the field and they've got an unequal pupil, that might warrant some concern. Well, the reality is, in general, if somebody has a dilated pupil on the sideline, you're already going to know it because that person is already too far gone. A dilated pupil is a very, very serious sign. And I'm talking about, you're not going to be deciding, God, is it 1 millimeter? Is it 2? No, it's different. And if that happens, you better hope you have a helicopter. Classic, when I was in Arizona, I was the team physician there, and I used to work with the Giants. And I wasn't at the field this day, but one of my colleagues was. And if everybody remember Matt Keogh, he used to be with the A's, and I think he got traded to the Giants. Well, they had just built this new stadium in Scottsdale for spring training, and they didn't have, it was just beautiful. They had open dugout, and somebody hit a line drive foul ball into the first base dugout. I believe it was first base at the time. And Matt Keogh got hit in the side of the head with a baseball. And everyone said you could hear it. It sounded hollow, almost like a pumpkin being smashed or something. And he went down. He didn't go unconscious. But because of the sound and how severe that blow was, they said, and the hospital is across the street. I mean, this is how lucky they were. They got him across the street, and as they were walking him across the street, he collapsed. They got him on a gurney, and they got him into a CAT scanner, and he was having a major bleed from a serious brain injury. So I guess my message there is that how an injury occurs is very important too. So if somebody hears something and that person looks fine, you know, and it really looked like a bad injury, you have to keep a real close eye on that individual, because sometimes that happens, right? Okay, they're fine, and then you put them on the sidelines, you go walking away, and your attention span goes to some other action on the field, and that person could be like this on the sidelines, you know, wobbly, and next thing you know, they could be collapsing. So it's very important to be aware that the symptom complex can evolve in a very short period of time, and that's another reason for the statement, when in doubt, sit them out. It's better to miss one game than it is an entire season. And that's what the Center for Disease Control has coined, and I think it's a good one. So now we're moving into what I feel are some of the more exciting parts, the newer parts of concussion. This diagram is courtesy of a company called SyncThink, who we purchased this device from, which I'll show you in the next slide or two. But we're knowing now that at least 80% of brain functions are tied into the visual cortex. And if you think about it, you've got the back of the brain, it's called the occipital region, is where the visual cortex is, but the eyes are up front. So you can imagine you've just got a lot of cross-pollination, cross-linking, etc. with the eyes. And so a doctor at Stanford, who's now at Stanford, he used to be in New York, his name is Dr. Jam Gajar, Ghajar. He and another individual, while they were on vacation in Nantucket some 20 years ago, were thinking, you know, maybe there might be something with eye tracking that might tell us something about concussion, because there is so much interrelated. And so these medical terms I have on here, nystagmus, smooth pursuit, saccades, I'm not going to go into those today. It's beyond the scope of this talk. But one I would like you all to be familiar with, you may not remember it, but it's called near point convergence, NPC. And you can all do it right now. And I'd like you to take your own finger, your index finger, and take it from a distance and move it slowly towards your face at about eye level, and note when that finger blurs into two fingers, or it splits into two. Not just blurs, but when it splits into two. If you're quote-unquote normal, then that's about 5 centimeters or less. So 5 centimeters, about so somewhere about that far away and in and closer would be normal. That term, near point convergence, is a part of a constellation of exam findings that we use to determine how prevalent or how severe a concussion is. And Mickey Collins, who's one of the thought leaders in the concussion sphere at the University of Pittsburgh Medical Center, has found that when that near point convergence, or NPC, is 10 centimeters or greater, he has data that says that that individual is probably going to have perhaps as much as 3 months recovering from the injury. So that's a very, very important finding. Now again, going back to what I said about the first 2 days, things are changing pretty rapidly. So you might have somebody come in. I've had people with an NPC out to 30, 36, very, very severe. And those individuals took a long time to come back. And you'll have them out to 20. So, but it's good to test that. You know, don't get freaked out in the first 2 days. Wait a few days and see where that number is. And if your doctor knows anything about concussion, they will be using that number. Now, before we get into Dr. Gajar and the device that we purchased here at Washington Township, devised a test called the King-Devick test. Mayo Clinic uses it. A whole host of professional teams use it. And in essence, what it is, it's a very simple test of cards that an individual is supposed to read the numbers off and read them as fast as they can while they're zigging and zagging. And it's time. And they do the baseline test on that, so they'll have the person read it and they'll say, okay, that person does it in 12 seconds. And supposedly, when they're concussed, if they read it even a second longer, that's an indication that there's a likelihood there's a concussion. Obviously, this was the state of the art. This has been used and it's been researched and found to be quite accurate and helpful. But one of the problems with it is, you can imagine, if an athlete does it over and over again, particularly in rehab, is there's a learning curve. They could get used to it. not necessarily memorize the numbers, but get familiar enough with it that so its utility really starts to fall out. So I bring you a drum roll with this unit that I think we have to be very thankful that the Washington Brain Trust, if you will, the administration has decided to support this. An interesting story is that Nancy Farber, who's a Stanford grad, was reading an article in the Wall Street Journal about this unit, and it was right about the same time that I was thinking of it, and so it was just kind of a lucky circumstance that, I said, hey, wouldn't you guys be interested in this? And next thing you know, Dr. Nord, myself, we're all involved in this and bringing this now to Washington. And the unit will be delivered. We're having 2 units. One will be in the Nakamura Clinic where I'm at, and the other will be in physical therapy where we do vestibular care so that an individual, when they come in for treatment, every time they step in, we can administer the test. So it all fits inside this little suitcase. Basically what it is, as you can see, it's a pair of virtual reality, actual Oculus Rift goggles that has been configured to give an eye track. It can actually track the eyes, and I'll show you what it looks like. And then it'll give a readout in just basically 30 seconds. It'll give a readout and a particular pattern of how the eyes track that is only found in concussion. They call them concussion whiskers, and I'll show that to you. This is what the readout's going to look like to us. These are the different individuals that are being tested. The numbers generally go from, so one of the athletes had a .18, average really high level athletes like pitchers and people that really have to focus like quarterbacks be like a .4. .8 is on the higher end. Over 1 is considered the civilian population, and obviously it goes higher from there. But it's not just the number. It is the actual pattern of the eyes tracking. This is what the eye tracking is doing. So it's basically giving you an idea of how tight the individual can follow a red dot that goes around for 15 seconds twice. This little diagram here is basically showing you this circle, if you will, on its side to show you how far on a side view or radial view the eye tracking is going. So if the eye tracking is really tight, you're going to see it on this radial or tangential view as well. And we can measure that. This is showing you a person with a concussion. You'll have to take my word for it, but this squiggly lines here, call them whiskers, and you see them better in the radial view here, are a sign of concussion. The best way to understand that is we go back in the talk when I was telling you how the eyes and the brain are trying to stay 2 seconds ahead, basically. They're jumping ahead. You may not know it, but it's happening. So what's happening in a concussion, remember the front of the brain is disconnected from the back of the brain, and the eyes are jerking. They're just desperately trying to find some kind of synchronicity. And that's, of course, why the company is named SyncThink and why the name of the device is called the iSync. Here's day 1, and the number on this person was like a 4. Now, the next slide would show you 2 weeks later. It's coming back to normal with treatment, and we'll talk about treatment. And you can see it's getting tighter, but you still have a few whiskers. 4 weeks later, here we are at 1.2. And just a tiny bit left, but it's just getting tighter. This is absolutely fantastic, if you can imagine, right? We actually now have a way to show a patient, and the clinician where you are in the progression of this syndrome. Before we had King Devic, or we still have this now, is a battery of tests that you probably, if you have kids, they've been involved in it. And this is a computerized neurocognitive test that I still administer and interpret. It's called IMPACT. And IMPACT was created out at the University of Pittsburgh Medical Center. And it's still being used, and it still has its place. It takes 30 minutes to do it. So it's not a sideline test. We do it as a baseline, and then when a person comes in, and they have their symptoms, we can test them again after a few days. We don't recommend doing an impact test if a person's still symptomatic, right? You can imagine if somebody's got a massive headache and they're just feeling unsteady, to ask them to repeat the impact test is going to be, you already know the results are not going to be good. Whereas with the iSync, we can put them on their head at any time and in 30 seconds have a readout. Simple. want to touch base on this just quickly, going back to, and the reason I put this here is because the University of Pittsburgh has still done so much in the concussion sphere that it would be a shame not to mention this particular very interesting part, that concussions have what's called a clinical trajectory. And very often that trajectory will follow any one of these 1, 2, 3, 4, 5, 6 realms. And then it will split off into these. And most of this is based on pre-existing conditions. So if you're young or your sex, you're female, you're at an increased risk. You could end up with a concussion, and if you have a history of learning disorders, you might end up with a more of a cognitive trajectory. If you're somebody that may be easily car sick, or has been known to have get sick easy, that person might have more of a vestibular component. Anxiety and mood, somebody who is an anxious individual, one of their predominant trajectories in their recovery would involve that. And so I guess the way to remember that is to think a concussion is like a bully. It's going to take advantage of whatever you bring to it. So if you understand the individual, and I mean this for the clinicians and our families that support them, that if a person tends to be a nervous individual, we have to reassure them a lot. And it's frightening sometimes to see them have issues. Depression, somebody can be a little depressed before an injury, and then that can become magnified. Remember what we said, that the front of the brain is involving emotions. And so those can get magnified as the brain tries to hook itself back up. So I just wanted to touch base on this, and there are different pathways for treatment for these trajectories. This is what the previous recovery and return to play, and it is still being used, it's still being recommended by the California Interscholastic Federation. We call them 6 phases. As a matter of fact, CIF is also recommending 2 days of off school. The basic idea is that what this is saying here in these 6 phases, it's saying rest, and we would used to say do not exercise or do anything until you start to feel better, and then go lightly. And then we'd say, okay, you're feeling a little bit better, move into sport-specific exercise, then non-contact, full contact, and then, okay, once you've had a full contact dry run, that's about as good as it gets, we'll let you go. And that would take about 7 days. And if you remember back to that slide on the cascade, where we were saying 7 to 10 days, the majority of concussions are going to get better in that time span. Then you throw in variables, as we mentioned, whether it's being very young, female, having pre-existing conditions, throw that all into the mix, and you can take something that would take maybe a week to 2 weeks to fully recover from, and you can stretch that out. What are the new guidelines? I would not call them, they're not guidelines for everybody yet, but basically our protocol, and the same as Stanford. Dr. Nord and I have been to Stanford, and we've been working closely with them, and Dr. Gajar and their head trainer. And basically, somebody gets a concussion, number one, they get the eye sync, diagnose it right off the bat. So if you know that somebody has that, wow, you can put them right into the concussion protocol. If they don't have it, then there's got to be another reason for the symptom complex. And that's how good this unit is. So if they do, they send them home right away. Get 12 hours of sleep. It is so important. If you've been in my shoes and seen enough people with these injuries, I had a lady recently referred to me who, very intelligent, PhD caliber individual, PhD person, who also had a 3-month-old child at home. And her husband worked. And I just said to her, I said, you have got to get sleep. I know how hard it's going to be for you with the child in the other room, but if you don't, you're going to end up taking something that's going to take maybe a week or 2 weeks, and we're going to drag it out to a month. So I saw her a couple days later, and she wasn't any better, and she said, I just couldn't, stay away from the baby. And I said, you have to. So she talked to her husband, and the next time she came in, she was already 50% better just from the sleep. What I'm also proposing is that if you have an athlete or a person that has a concussion, we're saying take 1 day off of school, that could be work. And the reason for this, I believe, is more of a chance to see how things are going, right? We know that with concussion now, we want to reintroduce that person back into an environment as soon as possible to get the brain to start to be able to synchronize. But remember what I said, in the first 1 to 2 days, those things are evolving. So if I see plenty of kids, right, they get injured on Sunday, they should not be back at school on Monday. As a matter of fact, I had met with Bellarmine, their head trainer, a while back, and Bellarmine automatically recommends they miss 2 days of school, and that's an academic institution. Right off the bat, you're not coming back for 2 days, because they want to give them that opportunity to kind of get their feet on the ground, do some of the exercises that they recommend, and I think that's very smart. So key here, key number 3, is doing some aerobic exercise daily. Optimally, it would be daily, but if you can get in 4 to 5 days a week, and we're talking about 15 to 20 minutes of getting your heart rate up, I would venture to say for most people that's going to be around 140. I'm just throwing that number out. There's calculations and formulas you can use to calculate this, but in general, you want to get your we call your rate of perceived exertion, where when you're exercising, you want to get it up to the point that you're having a very difficult time with a conversation, and you want to maintain that for 15, 20 minutes. Now, the key with this is that, well, what if they're getting symptoms, right? Well, you get them on an exercise bike, or you have them jog, and they're getting dizzy. Well, the athletes at Stanford, as long as you have that eye sync and you know that they're already improved with the sleep, they try to push them through the symptoms. And I recommend Tylenol only for headache. I recommend staying away from aspirin or ibuprofen for various reasons. I think Tylenol is a fine one to use. You can use it preventatively if you like. If they already missed their first day of school and they're going back their second day, give it to them before they go to school, or if they're old enough to put it in their pocket so they can take it later. But we want to get away from total shutdown. So we used to say, no screens, no music, no sounds, no nothing. Just do nothing. And really all we're saying now is go home and get some sleep and come back, and we are going to start exercising you. And I threw in this part, throw in some hand-eye coordination. I tell all my patients now to get a tennis ball and just start throwing it in the air and catching it with one hand and do it in the other. Just start practicing getting that eye synchronization. And it's amazing when you talk to your patients, they'll say, God, the first time I did that, I dropped it 2 times. I couldn't believe it. It was just something so simple. And then you can work up to having him throw the ball against the wall, whatever creativity you can come up with. And then, as I talked about before, was that NPC number, near point convergence. You won't remember that. You might remember NPC, but remember that number, and that's helpful too. Before we're getting this unit, I was using the NPC number pretty successfully with my patients to give them some feedback. You are getting better. Look, your number was 20 before, now you're down to 12. Now, wow, you're at a 3 now. So this is fantastic. Now we actually have a unit that's going to give us a scientifically verified method for determining this. We should really be proud of our hospital and administration for supporting us in this. Thank you.